Good evening, everybody, and welcome to this presentation on everything that you need to know about back pain. My name's Claire Small. I'm the Clinical Director and one of the co-founders of Pure Sports Medicine. And joining me tonight is one of my colleagues, fellow physiotherapist, Stephen Armstrong, who is a specialist musculoskeletal physiotherapist, and he's also the clinical manager, clinical lead at our clinic in St. Paul's. I'm going to kick off with a few background slides, and then I'm going to hand over to Stephen to talk about the sort of more detail. And we really value sort of audience interaction, audience participation. So please feel free to put some comments or ask some questions into the chat function or the Q&A section of your screens and things. And what we'll do is that after Stephen's finished, we'll pause and take some questions there. We'll be monitoring it throughout the proceedings. And then once we finish the webinar, we'll take some further questions and things as well. So we want this, as I say, we're probably going to be talking about some stuff that may be completely contradictory to your current understanding of back pain, and we want to make sure that everybody really does go away with all of their questions answered, and things that are clarified that may be completely inconsistent with what you have understand or have heard to date regarding back pain as well. So I'm just going to share my screen with you. So, as I said, I'm the clinical director of Pure Sports Medicine. I'm also a consultant physiotherapist, and I still manage patients at our Kensington clinic 2 mornings a week. I'm a fellow of the Musculoskeletal Association of Chartered Physiotherapists, which is the special interest group and the specialisation group for physiotherapists in musculoskeletal physiotherapy here in the UK. And Stephen is also a member. I've been in private practice in London for over 26 years. So in that time, I think that I've gained some insight into the challenges in managing back pain, both from a practitioner perspective, but I think I've also come to have good insight into what concerns patients when they come to seek treatment for a problem with their back pain, and what they find challenging throughout that patient journey. And that's some of what has led us to presenting tonight, and also to talking a bit later about some of the sort of packages of care that we've chosen to put together to help people manage their back pain more effectively, or manage it in the way that they feel is appropriate for them. You'll probably be pleased to hear that my special interest, speaking on the subject tonight, is in low back and pelvic pain. I lecture nationally and internationally, so on a number of MSc programs and things, and I'm also involved in research in that area. And I'm the co-author of a textbook for clinicians on managing the injured athlete as well. So I said that after 26 years, I think I understand some of the challenges for patients around back pain. And I think one of the biggest challenges, and one of my biggest frustrations, is the amount of inaccurate health information that is out there in the press and on the internet. And, we sort of talk about medical knowledge having a half-life of 10 years. And that means that in every 10 years, half of what we used to think was gospel truth about, say, back pain or any kind of medical condition is actually been shown with research to be completely inaccurate. And I think you only have to think about how our knowledge around coronavirus has changed in the last year, and how our mechanisms of treating it and our sort of understanding of how it spreads and things has changed massively. And obviously, what's happened in the last year is something that would normally take a lot longer to occur if it wasn't such a sort of life-threatening and a global pandemic and things. But the same thing happens with back pain. So, what I learned at university all those years ago, a great deal of it has now been shown to be inaccurate. And unfortunately, what happens is that we have two things occurring. Firstly, that the internet doesn't, we don't update information on the internet. So there's still a lot of information that is actually inaccurate, that is still left up at various websites and things. And the second thing is that not all clinicians do keep up to date. So a lot of clinicians are out there providing people, both in the media and as patients, with inaccurate information. And that can be really frustrating as a patient, because how are you supposed to know that? And that comes back to the second point of mine, which is that, as patients, you really have a lack of information of what good looks like. And healthcare is one of the few industries where there really is very little indication of what good looks like. We don't have, 5 stars in the same way that hotels do and things. We've only just started to get things like Google reviews and Trustpilot reviews out there to get information from patients about what they perceive good looks like and things as well. And so again, I think it's really important that, as clinicians, we have a responsibility to try and really inform and educate people about the latest information regarding various different healthcare conditions. And that's very much what tonight is all about. I think the other thing that's really challenging and often quite frustrating for patients as consumers of healthcare is undefined costs. So when you go and see a clinician, whether that's an orthopedic surgeon, a physiotherapist, an osteopath, a soft tissue therapist, about your back pain, you really don't know how much it's going to cost you in order to achieve the outcome that you are looking for. And that might just be that you actually just want to know what's wrong with you, want some reassurance and things. Or it might be that actually you want to get back to being able to run a marathon or take, part in a triathlon and things. And there really isn't anything at the point of initial entry into the system that gives you an idea of what it is that you're purchasing. So you also don't know necessarily when you go to see somebody, and people aren't necessarily used to saying to somebody, well, actually, this is what I want from you. I think it's one of the things that we as clinicians are getting much better at asking our patients is, you're here to see me. What can I do for you? What is it that you want to get out of either this session with me or, a number of sessions? What are your goals and objectives? And so what we have done at Pure Sports Medicine, and I'll be talking more about this later, is that we have come up with some specific healthcare packages relating to back pain that give people a very set information about what it is that they would get with these packages and exactly how much those packages are going to cost, so that people really do have choice in the decisions that they're making about how they want to go about managing their back pain and how they want to go about purchasing that product. So just for those of you that don't know a bit more about Pure Sports Medicine, we are a multidisciplinary sport and exercise medicine clinic or organisation. So by that, and again, a lot of people don't know what we mean by the term multidisciplinary, but that means that we've got a number of different types of clinicians all working together under one roof to help you achieve your goals. And in that respect, the way that I talk to patients is I say, we're very much like the sort of sports medicine team that you would find at the English Institute of Sport or at Liverpool Football Club. And that our aim, in the same way that the aim of a sports medicine team operating in those environments is to get their players back on the field and help them achieve success, that is our aim as a team. So it's not about us as individuals, it's not about us as clinicians, it's about you as the patient and what you're wanting to get out of seeing us as clinicians. And I think that the idea of a multidisciplinary team is really important to us because we don't want to be jack of all trades. We want clinicians who are really specialist in their unique areas, where they have a superpower and a skill set that can help the patient achieve their goals. We're not trying to be all things to that individual, we're not looking at, as I say, being jack of all trades rather than master of none. And I think when I talk to people, one of the other things they say is, well, you're a sports medicine facility, you're called Pure Sports Medicine. And it's like, no, it's not because we want to treat sports people in this organization. It's taking the concept of the medical team that operate in sports medicine and giving that ethos to the patients that we see. So again, just to prove that actually, we don't just treat sports injuries, 15% of all of our patients present with low back pain. So a large percentage of what we see is people with back pain. And we measure our effectiveness with all of our patients. So we use what we call outcome measures. So, and this is the outcome measure that we use across the board is the patient-specific functional scale. And that outcome measure is very much designed around patients' goals and objectives. And the aim is for us to help the patients get as close to achieving full function with those individual goals and objectives as we can. And again, across the board, you can see that on average, we get an improvement of 6. So with 6 sessions of physiotherapy, we get a 4-point improvement in that patient-specific functional scale. And that is very much a clinically significant difference. So in terms of actually really demonstrating a real change in patients' symptoms and in their function more specifically. And we do that using an individualized bespoke plan that's designed to help patients, to guide them through their recovery and help them achieve their goals. And Stephen's going to talk a little bit more about, how we do that. And then I'm going to come back at the end of the evening and talk about some of these specific packages that we have devised that people can choose to select for their healthcare. So I'm going to hand over to Stephen now.
Okay, so to follow on from Claire's points about some of the medical literature and that's out there and about the knowledge that is out there for patients regarding their back pain, we thought tonight would be a good place to start about giving you some of the basic information around the anatomy of the spine. We'll aim to try and talk about some statistics around back pain and how prevalent it is, the different types of back pain and how they can affect us. We'll look at why we might need a scan and their role in terms of the medical management of patients. And then we'll try and discuss some of the common myths about back pain and how we can, you can use yourself to get better and then when to try and seek help. And that will then lead in very nicely into the new packages of care that we've designed at Pure Sports Medicine. I can already see a few questions ticking into the question and answers box about back pain. So I'll aim to address some of those at the end after we've talked a little bit about this, because actually some of this information might help to explain some of those questions before we get there. So as Claire said, I'm an Irish physiotherapist, if you didn't get it from my accent already, and I'm a clinical manager based at St. Paul's Clinic in the city. I'm very much interested in spinal-based patients, and particularly areas of persistent or ongoing problems with back pain or neck pain that doesn't seem to be resolving under the normal measures. I completed my master's degree in manual therapy and finished that in 2019 up at Coventry University. And I'm also a member, as Claire mentioned, of the MACP. I'm not yet at the standard of fellow as my good colleague Claire is, but hopefully one day we'll get there. From an exercise perspective, I absolutely love running. It's one of my key tips for myself to keep my own back in check, as I've suffered for many years with my own back on and off. And running is, if you've been treated by me at any point, if you've joined the webinar, you'll probably have seen some of my biases push you down that route as well. I would love if you would like to follow me for more information on Twitter. You can find me at Stephen Armstrong 87, or if you have any other personal questions after the talk, you can send me an email and Claire the same to the email address provided below. Next slide, please, Claire. Thank you. So to start, we want to try and break down ultimately what the spine is. So the spine is 24 bones, and those individual bones are known as vertebrae. And ultimately, they consist of 7 bones in the upper spine, 12 bones in the mid spine, and 5 bones in the lower. And then there's 2 naturally fused bones at the very bottom, which is from when we develop the end of our tail, hence why it's known as the tailbone. And ultimately, this looks like a graceful, elongated curve. And those curves are referred to in medicine as kyphosis or lordosis, depending on which way the curvature goes. So in the cervical spine or around the neck, That's known as a lordosis, and in the thoracic spine that curves around, that's known as a kyphosis. And in medicine, we ultimately break down these areas into these chunks because their role and the structure of each individual vertebra differs depending on which aspect of the spine we're discussing. So the reason why we have these three different areas is because their structure and design is slightly different to allow for different aspects of movement. And in the neck, the design here is that the movement is of main priority. First, to stabilize our head and our eyes and our visual field, but also to allow almost 360 degrees worth of motion to allow us to look left and right and to assess dangers that may approach us. In the middle back, the bodies are a little bit thicker and they're designed predominantly to allow the thorax or the attachments of our mid-body to that, and they also allow us for rotation in the mid-spine. In the lower spine, however, you'll see on the picture on the right-hand side the three different vertebral bodies. You can see on the lumbar spine it's much bigger and broader, and that's designed to act as almost the load bearer of our spine, but also allows for forward and backwards movement. It's designed to do that predominantly. And ultimately, what you have to remember about the spine itself is its main role is to ultimately act as a protective scaffolding for our spinal cord, which is a very important piece of our anatomy, which allows the nervous system to fire signals to our peripheries and to our different aspects of our anatomy. And this scaffolding ultimately acts as a strong, rigid structure for our muscular and other limb attachments to form to. Next slide, please, Claire. Now, in between these vertebrae, we have these wonderful things known as intervertebral discs. And I'm sure at some point in any of your back pain journeys, you'll have heard the word disc at some point. Discs tend to get a very bad rap in all forms of media and in the medical literature. And ultimately, what you really need to know is they are of a very unique and complex structure in our anatomy. They are the largest avascular structure within the human body. And by that, we mean that they do not get an adequate blood supply. So unlike our muscles or our skin, they don't necessarily get a direct blood supply, which supports them with nutrients. So as a result, they have to design, or their design means that they will get nutrients from other aspects. And they ultimately get their nutrients from two end plates that sit at the top and bottom of the disc, which are attached to the vertebral bodies. And this allows the disc to draw in nutrients from different activities that we will do in our life. So sitting or standing or walking or running, and doing these general movements will allow compression and stretch through the disc as the day generally wears on. This is a very important function that makes discs healthy. And it's a common misconception around back pain that if my disc is a problem, I need to not do certain activities because that will make it worse. But ultimately, discs are an extremely strong and very robust structure. They're designed to act as an efficient load transferer to assist movement of this spinal column, and they are very effective shock absorbers. The dynamic structure of the disc, and you can see that in the above schematic, the very top one, you can see the outer area has got these kind of cross-laminated fibers, and that makes it a very, very, very strong structure on the outside. And that's known as the Annulus Fibrosis from the medical terminology. And fibrosis in that term means tough, it's strong. In the center of the disc, there is a more gelatinous style structure known as the nucleus pulposus. And in some aspects of the media and some other forms of television that were published recently, they were renowned or they were described almost like a jam donut, which is a terrible description to describe a intervertebral disc because it is certainly not as gelatinous as that, and they are far more robust. If you look on the right-hand side pictures, you'll get to see true anatomy shots of what an intervertebral disc looks like. In picture A, this is a healthy, normal adult disc. You can see the intervertebral rings of the disc on the outside, and in the center, you can see it almost looks like a gelatinous tough mass in the middle. In the second picture, you will see an aging spine or an elderly spine, and you can see that gelatinous mass has become a little bit more fibrotic or a little bit tougher from that perspective, and that allows, that's the normal process of aging. We would normally call that on MRI scans a degenerative change. And on the lower part, you'll see a disc of a juvenile or a young person. Now, from that perspective, all you have to know is that there's one very famous adage that was known as the slip disc. This came about from two orthopedic surgeons based in 1911 from New York, who were orthopedic surgeons at the time, and they described slipping the disc back into place through surgical intervention, and that adage is stuck for a long, long period of time. I suppose the final points on the disc is they can change height throughout the week or throughout the day. So when you start in the morning, you're between 13 and 21 millimeters taller than you are at the last thing at night. But if you were experiencing a lot of back pain and you've taken to a long period of bed rest, which some patients are sometimes advised to do, actually that creates more expansion within the disc tissues. This is reversed over normal time frames of about 5 weeks when you start walking or moving again, but that can actually trigger some more levels of discomfort at times because the disc is not going through its normal compressive cycles. And a fun fact from that is astronauts are generally susceptible to lots of back pain because of their weightlessness in space for long periods of time, and it takes them approximately 5 weeks to return to normality afterwards. And if you can just click next there for me, Claire. A funny adage that we've all heard is discs don't slip, they never will, and they never have. And that again comes from that old orthopedic surgeon back in 1911. So it's taken us a long time to continue to try and push that message that they don't slip and they don't come out of place, but they can change or change shape, and that may be a reason for some patients' pain. Next slide, please, Claire. The current state of back pain, ultimately back pain is an extremely common affliction and affects all age groups of all different activity levels. In 2017, the prevalence of low back pain in particular was about 7.8%, or about 577 million people across the world at any one time. So know this, you're not alone in your endeavors to try and solve your own back pain. Lower back pain is now the leading cause of disability globally, worldwide. It has overtaken many of the other major forms of disease that we see in the medical industry. And the development of chronic back pain is normally now overrepresented in some of the lower socioeconomic populations. And this sometimes is as a result of lack of information or knowledge translation into these populations. There's also a 1-year reoccurrence of particularly persistent low back pain, which ranges from between 24 to 80%. So again, if your back pain is sometimes reoccurrent, again, you're falling within the normal trends of some patients that we would see. And ultimately, the burden of back pain is, as it says here, a massive problem which seems to be treated badly. And why are better approaches to helping sufferers slow to spread? And the talk of this is a very challenging point, but ultimately it's, as Claire mentioned earlier, sometimes the knowledge translation of this is slow to filter down to practitioners, and as a result, that leads to poor and ineffective care. Next slide, please, Claire. The types of back pain it is often generally not possible to directly identify causes of back pain, but broadly we can split it into 4 main categories. The first category, which would affect 95% of the population that we would see with back pain, would be known as non-specific back pain, which for some people can be a little bit of a misnomer diagnosis, where it just doesn't quite give them the answer that they're looking for, but it's ultimately given as an umbrella term because there's so many structures that do attach to the spine that may be involved that it's hard to definitively pick out one. The second of which can be back pain, which is associated with some limb pain or neurological irritation, such as pins and needles or burning or symptoms that travel down your leg or into your arm. This can be known as sciatica, and in medical terminology is also known as radiculopathies. This affects approximately 5 in 100 people, or about 5% of that population. In smaller groups, particularly in the UK, there is a small cohort of patients that may be of the subset that fall into inflammatory back pain. The sources vary on the statistics here, but they're between 3 and 7% of the population. The mean time of diagnosis for these patients is approximately 10 years. And generally speaking, we'll talk about the signs and symptoms of this next, but they generally have other medical conditions which would predispose them to having this style of back discomfort. And that is usually diagnosed by medical practitioners, but often missed over a long period of time. Serious pathology, which is always the worry for most patients when they experience back pain, is less than 1 person in 100, or less than 1%. And when we talk about serious pathology, we're talking about cancers, fractures, infections. So things that require urgent medical attention that ultimately physiotherapy would not be able to treat within our clinic remit. Next slide, please, Claire. The signs and symptoms then of these vary across many different versions, but non-specific back pain being the 95th percentile, in the majority of cases usually caused from overdoing something or not doing enough activity actually. And this can present usually as aching, stiffness, difficulty with sitting or standing, particularly for long periods of time, or pain in certain movements or styles of exercise. In back pain with leg or arm pain, or the sciatic or radiculopathy-based patients, this can be caused from changes in the spine, such as degenerative aging changes within the spine, which may include disc bulging. So we said they don't slip, but they can change shape. And if they change shape and narrow the canals of where the nerves exit, that can cause inflammation around those roots and ultimately lead to symptoms that may travel along a nerve root. These commonly present as a strong aching pain in either your neck or your back, and it's usually accompanied with altered sensations in either your arm or your leg, depending on where it's affecting you. And these can take the form in many different shapes, but ultimately most patients would report them to be pins and needles or creepy crawling sensations or a strong dull aching pain in their limb. In relation to the inflammatory back pain, like we discussed, usually the presentation of these patients is they usually started with back pain quite young in their lifetime, so usually within their teenagers. Their pain is often localized to their lumbar spine or the lower back, and is usually associated with some buttock pain that may alternate from side to side at times. These patients generally have a long history of stiffness in the mornings, usually that lasts longer than 30 minutes, and things tend to get better with either exercise or non-steroidal anti-inflammatory drugs like ibuprofen. These patients tend to also present with other inflammatory conditions like I mentioned, such as psoriasis, IBS, or Crohn's disease, or some form of rheumatological arthritis. In relation to the sinister pathologies, there is a number of red flags questions that you will be asked by medical practitioners, which will aim to rule out that as part of your history. But there was one such condition known as cauda equina, which is an emergency condition, which you will have a number of symptoms that will link to that. And if this is the case on some of your assessments, or if you are presenting with these symptoms, you will often be sent for emergency review and imaging to rule out this as a condition. These symptoms may include difficulty in passing urine, difficulty with opening your bowel, having numbness in around your genitals or back passage, usually having pins and needles in both legs that's persisting for long periods of time. And if you had a previous history of lung, prostate, or breast cancer, this would also be a red flag or worry for us. And if so, you should contact your professional. If Claire clicks the next slide, you will see a red flag warning card that the MACP, this Musculoskeletal Association of Physiotherapists, came up with in an attempt to try and educate the general masses about what these symptoms may feel like. And as it says in the red box, any combination or number of these warning signs could be symptoms associated with this rare and unusual condition, but you should seek emergency help within 12 to 24 hours if you are presenting with this. And these are ultimately some patients that may attend us and tell us these symptoms. And as I said, they would be sent off for further investigations. Next slide, please, Claire. Now, we've talked about further investigations, and what does that mean? Well, for lots of patients, it often means, do I need a scan? And it's like one of the most common questions I get asked when I treat patients with back pain. And ultimately, the guidelines, if we look at the medical literature and the guidelines on scanning patients, they ultimately recommend against not imaging patients unless we are suspecting serious pathology. So as I've discussed previously, that's less than 1% of patients. So really, imaging should be a very much last resort unless we deemed it something of significance. And a very recent systematic review that was done by Steve Kemper and colleagues, who's a prevalent researcher in this field, he found that looking at lower back pain over the last 10 years between 95 and 2015, that the findings were suggestive of about 24.8%, or about a quarter of all patients are being investigated for with MRI scans or imaging scans. And as a result of having this very complex imaging such as MRI and CT, that sometimes can create more worry with patients because we get a lot of data, a lot of information from these pictures. But I like to use the analogy, a lot of the time, if your car is not running, you can open the bonnet and have a look inside the car, but it still doesn't tell you what the problem is. And a lot of the time with patients, scans act in that same format. We can scan a patient and find very little wrong with their spines, and that can sometimes, they can still have pain and not explain why they have that discomfort. And if you move on to the next slide, Claire, this follows on to a very prevalent study that was in our literature by a researcher known as Brzezinski. And he did this study in 2015 where they looked at a large cohort of patients and imaged these patients to find out what the prevalence of these changes on scanning were in patients who don't have any back pain. And if you click again next, please, Claire. The next chart that you'll see is the percentage of findings that we would see commonly reported on MRI findings, but these patients that you're seeing here have no back pain. at all. So I'm in my 30s. And if I was to comment on what my imaging findings would be for my own back, I have a spondylolisthesis. So thankfully, I'm actually in a small cohort. That's only 5% of patients would have one of those. However, if I had some disc degeneration or disc signal loss or a disc bulge, for example, I'd be falling between a 30 and 50% percentile of patients who don't have any back pain, but also have the similar findings as me on scan. So what does that really tell us? Well, ultimately, it tells us those things are natural process of aging, like your hair going gray or like you're getting wrinkles on your face. These things are the natural signs of an aging spine as we develop over our years. And a lot of the time, they're not something to mainly worry about unless there's a significant change on the scan, which may be indicating that these are the main source of symptoms. But ultimately, what we're getting at is that pain is a more complex approach than just the structures alone of the spine. Next slide, please, Claire. So there was a very prevalent study that was released very recently by a very good author known as Peter Sullivan. He's a New Zealand-based physio, but he works in Australia. And he is very keen to try and publish this information that we're trying to tell you. And he created an infographic, which you can see on the right-hand side of your screens, which is the back facts, the 10 facts regarding back pain. But accompanying this, he also put together the 10 myths surrounding low back pain. And ultimately, the myths that most patients would tend to come to us with would be that they're worried that the low back pain is a serious medical condition. As we've discussed, 95% of our patients would fall under the remit of non-specific mechanical back pain, and this is not something that is a significant medical condition. The second myth that's commonly portrayed is that it will get worse and deteriorate with age. Well, from the studies I've shown you from Brzezinski et al., that shows you actually it's normal age-related processes, and actually back pain doesn't get any worse with age from what we know. Back pain affects all age groups equally across the board, from young to old, in equal measure. Persistent back pain is the third myth that is always related to tissue injury. Well, as we've discussed already, the scans and that doesn't necessarily add up. And most patients who have persistent low back pain tend to have other aspects that are contributing to their pain, whether it be their social world, their activity, their fear regarding their back pain, their thoughts and their beliefs on how they think they should move or how they think they should act. And those things are all contributing factors to how pain works. In relation to the myth number 4, we have discussed scans are always needed to detect the cause of low back pain. In most cases, they are not. In only a very small percentage of cases are they helpful. Myth number 5, then, pain related to exercise and movement is generally as a result of you causing more harm to yourself. Well, a lot of times the pain that you're experiencing in the early stages may need a short period of rest, but in longer term patients who have had pain for a long period of time, exercise is one of the main forms of recovering from that. And at times that can be uncomfortable, but a lot of the time it will not harm you. It might hurt somewhat for a short period of time, but it will not cause any long-term harm. Myth number 6 is related to posture. And I noticed that this was a question that was posed already, whether poor posture when sitting, lifting, or standing is as a result of the cause of your symptoms. Well, in the recent literature at the moment, we're now seeing that this is not a relatable finding in terms of patients with back or neck pain, in terms of how they sit or how they manage or how they move. And actually, it's probably more to do with the fact that they're not moving enough rather than how they're sitting. They're staying static for such a long period of time in the day and not fitting in any activity. And it's actually a reason, that's the main reason why they're getting symptoms rather than how they're sitting or where they're sitting. Myth 7 is lower back pain is caused by weak core. This was also addressed in some of the question boxes. Well, the core is a very interesting topic. Ultimately, the center of us is a cylinder that needs to be both soft and dynamically strong at times. But the core ultimately, when I talk about it with patients, is a combination of confidence to move and lift, but also the activation of your gluteal muscles and your abdominal muscles in a fashion that's deemed to be effective. Now, core-specific exercises have been shown actually to in some cases to worsen patients as it increases the increase in pressure in your abdominal cavity, which can actually increase the pain in your lower back. And actually, it's about having a core that's both strong and relaxable in equal measure without something that's working too hard all the time. And this is a common mistake that I see some patients who have had pain for a long period of time making, is they are investing far too much time into just abdominal or core-based exercises and not focusing on the normal movements that would be required in their back. Myth 8 then is repeated bending results in more wear and tear tissue injury. Well, again, your lower back, as I said earlier, is designed to move and it's designed to bend in many different forms or fashions. So certainly you're not causing yourself to wear out by moving in those patterns or those ways. Mid-9, then pain flare-ups are a sign of tissue damage and require testing. As we've said already, chronic back pain is a constant flare-up of between 24 to 80 percentile within a year. So again, flare-ups are quite common, and it's about managing those and looking at what may be the contributing factors to flare-ups, such as activity or stress levels, or your beliefs and your feelings regarding your back. Finally, the myth 10, which is a common one, treatments such as medications, injections, and surgery are effective and necessary to treat lower back pain. Now, in relation to medications, I think in the early stages, they can be very helpful to allow patients to overcome nasty symptoms at the start. But for long-term patients, we've seen that the evidence does not support long-term use of medications in long-term pain. Injections can be diagnostic and allow us to determine which structures may be causing some of your back pain. But again, the evidence would suggest that long-term, these patients don't do any better or worse than if patients were to exercise and change some of their lifestyle habits. And in relation to surgery, again, sometimes surgery is required and necessary for patients. However, those patients, again, would be in a very small minority, approximately 1% of what we would see. Next slide, please, Claire. So what should you do? What can you do yourself to try and improve your symptoms of your back pain? Well, one of the most important things that I can tell you is to try and stay as active as possible and to try and continue your activity or daily activities throughout the day. And the reason why this is the most important thing you can do, because when we've discussed already, sitting and resting for long periods of time can actually worsen your back pain. It can change how the dynamics of our physiology in terms of our back, our discs and our muscles, and how they contribute to normal, healthy spines can deteriorate for periods of long periods of rest. So it's important to maintain activity as much as possible, even in the early stages. Taking to the bed is usually the worst medicine that you can do. The second, we've seen across the literature in medicine that walking has been very effective form of pain relief for back pain sufferers. But you can also try a variety of different forms of exercise, such as stretching or strength training, as well as swimming, yoga, and Pilates have all been rumored and purported to be effective. But ultimately, all of these forms of activity are just movement in different and variable ways. And actually, that's the secret weapon to helping patients with back pain, is returning them to normal, active lifestyles. You can, as I said already, take anti-inflammatory medications such as ibuprofen or paracetamol, such as over-the-counter medications that you can get from your pharmacist, but you should check that with your pharmacist or GP to make sure you can take those medications before you do so. If you were to take a course of anti-inflammatory, such as ibuprofen, it's encouraged that you take them for a period of days rather than intermittently as you would like to. We usually find that if you take them for a course of between 5 and 7 days, you'll have a better effect, similar to an antibiotic. And the reason for that is the effects of the drugs have a very short lasting effect in our blood system. So you need to top them up at regular intervals. And that's why the packet tells you to take them 2 at every 4-hour intervals. These are helpful in the very acute or early stages of back pain. You can also use hot and cold therapies, but these provide short-term relief. Lots of patients tell me there's nothing better than a hot water bottle or sitting on a bag of frozen vegetables to kind of ease off some of their symptoms. But you must remember that this is ultimately just interrupting the signal that's going to your brain, and it'll tell your brain ultimately that all I can feel is hot, 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 or cold, cold, cold for that period of time. And as soon as you remove that, pain may return in a short space of time. So it's ultimately interrupting or changing how we perceive that level of discomfort. The final point here that I tell patients to consider is I know things can be difficult with back pain, and I know it can really drastically affect patients' lives, and I've seen it happen in clinic. But it really does help to stay as optimistic and to recognize that there is a way out of this, and your pain will get better over a period of time. And it has been shown that people who manage to stay positive despite their pain tend to recover and make longer term recoveries in the future. Next slide, please, Claire. So finally then, when should you seek help? Well, as I've said, remember that back pain does usually get better on its own within a couple of weeks or months. And you may not need to see a professional regarding it, but it's usually a good idea to come and seek help from us, particularly if your pain is not starting to improve as you would expect it to over the few days or weeks like we've described. Particularly if your pain is intense enough to stop you from doing those day-to-day activities like I've encouraged you to do, like walking or moving in the house. And if it's significant enough or getting severe and you feel it's worsening over a period of time rather than improving. Also, it's very, very much approachable to say that if you're worried about pain and you're struggling to manage this at home, that's when you need to come and seek help. That's what we're here to help you with, is to guide you through a journey of recovery. And lots of patients do struggle with this because it does impact their lifestyles an awful lot. And that then takes us then forward to how we can offer to help you Pure Sports Medicine, which brings Claire back into the discussion to discuss our packages moving forward.
So, well, I think thanks very much for that, Stephen. I mean, I think I'd also sort of like to say that, you know, the other things that I would suggest you should use as a guideline for when to seek help are things such as, you know, if you're not sleeping, if you're really struggling to get a decent night's sleep, that's can sometimes be a sign that, you know, things are starting to get a bit spirally out of control, because obviously not sleeping can also make things harder in terms of just your the feeling of pain and things. And obviously, if you're not able to work because of your back pain, that's not something that you should just put up with. And, you know, it's often a good idea at that point to seek treatment, you know, even so that you have a better understanding of what's actually happening with your back and things, and to get some guidance and advice as to how you move forward from there. I think at this time, you know, we're seeing a lot of people who are coming to see us with back pain. And as Stephen said, a lot of it is because we're spending so much time sitting down. So we're not moving nearly as much as we used to when we were commuting to work or taking the kids to school, or just being able to be outside and more active. And even if we are doing and undertaking our regular sort of 1 hour of exercise a day, what I'm seeing with my patients is that they're going out and they're doing some exercise either in the morning or in the afternoon, but the rest of the day they're spending sitting. So they're doing it's extremes of an hour outside and then coming home and then spending all the time sitting at their computer working and things. And, you know, I know one of the questions in the chat was about posture and this idea of good posture, bad posture. And as Stephen was saying, we now know that there is no such thing as good posture or bad posture. Everybody is an individual, and, you know, and we need to use pain as a guideline as to when we should be moving, and that it's the lack of movement that causes the problem rather than any particular position that people are sitting in. And the way that I describe that to patients when I speak to them, it's the same as if you walked around with your fists clenched or your jaw clenched all day. That the lack of movement of those structures means that you're not changing the pressure on the tissues, that you're not increasing the circulation, you're not so you're getting ischemic changes within the tissues, and that's naturally going to cause pain. And in a way, that pain is the warning signal that you should be moving and you should be doing something different. So before we talk about the packages, just want to see if there's any sort of more further questions that you want to answer in the chat, Stephen.
Yeah, there's a few questions there. So I've just seen one pop into the chat here, and then we've got a few in the Q&A, but there's a good question here saying that one of our panelists works for the NHS and found explaining to patients that they don't need an MRI to be quite challenging when they really, really want one. And it's a common problem that I've seen and talked to colleagues about often, where patients really need it and it's their expectation to have it. And I suppose this is the challenge that we face in terms of this knowledge translation has filtered down to patients when they've come to see us. And it's very difficult to have those conversations, but I do think we need to be resolute in our approach and our advice to say that from what we know, and provide additional reading and references and reports to say that this is the way things go. And I used that Brzezinski graph, or that slide that I showed you with the statistics, often to describe to patients why I don't feel it's relevant for them to have a scan. However, I do sometimes have to cave and do need to move those patients into scans, because if that's the only thing that they need to allow them to move forward with what we're describing to them as the journey out of back pain, well, then perhaps then we really do need to give them that scan. And it's again, as Claire said, every person's individual, and we need to try and assess their individual needs to what they need to recover from. And if that's all they need, then potentially we need to discuss that with the patient or with the team in a wider conversation to say, look, perhaps we do need to send this patient, or perhaps we don't. And it's again, it's a very challenging topic, but I do enjoy the question. Claire, I don't know if you have any other points on that.
I mean, I think, again, if we are going to send the patient for a scan, I think it's really important to preempt the idea that we're likely to see some of the changes that you've talked about on the scan, and that they are normal age-related changes. The other thing I talk very much about is that, you know, we only scan people if we feel it's going to actually change our management of that individual. Yeah. So if it's going to, you know, we use it as part of our treatment planning and things. And I think the other thing that I use very much in terms of explaining to patients why, even if they have had a scan and we've seen, you know, degenerative changes or maybe some disc degeneration or a disc bulge, I talk to them about the idea that if they can have a pain-free day, then that's an indication that it's not the structure that is causing that pain. Because if it was the structure alone, it would not change. So, you know, you don't have pain coming from a structure one day and then not coming from a structure another. And if you take it to an extreme, if you talk about a broken leg, if your leg is broken, it hurts 24/7, 7 days a week. It doesn't change. And it would be exactly the same if the pain was coming from something structural. So I think it is challenging. And again, that's where it's really important for us to, as clinicians, to be consistent with our messages to patients about why scans, you know, are not helpful in managing most back pain and things. And I think the most important thing for patients is that they feel listened to, and that conversation as to why they are not being referred for a scan is that it's not just about the finances and things. It's actually that this is really about looking at what is really in the patient's best interest.
Do you want to pick a question there, Claire, or do you want to?
So I'll move on and talk about the packages, and then we'll come back to some questions at the end.
Super.
So as I've said, you know, what we've done at Pure is that we've put together some back pain packages for patients to really help people feel that they're making decisions about how they want to manage their back pain. And, you know, what we say is that no one knows your back pain like you do, and no one knows how to fix it like we do. And, you know, when we say no one knows your back pain like you do, that's also about no one knows what you want to do about it. So some people, you know, aren't necessarily that bothered by the fact that they have back pain. It doesn't, you know, they're aware of it, but it doesn't, they don't feel it stops them or impedes their lifestyle. Whereas others are very concerned. And so the way that people choose to manage their own back pain is very individualized. And again, that's something where we want to try and offer patients choice as to how they manage their back pain. So we've created 4 very simple packages. So the first package is I want to self-manage. So this is actually just a one-off session with one of our expert spinal physiotherapists. And it's designed ideally for people who are experiencing a first-time episode of back pain or new back pain, or have had intermittent back pain, but aren't having long-standing problems and things. And it's really designed to provide a lot of information, advice, a specific diagnosis from the clinician about the condition and what's going on, a management plan, as well as educational content and an individualized exercise program. And so, and again, people can come in, they get that package, it gives them the information and advice, and then they're very much then free to manage their pain as they see fit. Now, if people then want to seek subsequent care, we're very happy to provide that, but the program itself is at one-off guidance and advice package. The second program is someone who's someone's had back pain for more than for under 3 months. And but where they really feel that they want something a bit more focused. And so this is 3 sessions with one of our expert physiotherapists. And again, it's the diagnosis and 2 follow-up sessions. And the aim is to really help guide you through that management program in terms of reducing pain and improving function. Obviously, it comes with an exercise program, because we've talked extensively about how important exercise is. But the exercise program is specific to you as an individual in terms of what the clinician determines is appropriate to help get you back to full function and things. These programs also come with, we take outcome measures, so we review the patients, and they also come with follow-up as well to see how patients are faring further down the line to make sure things are improving. The third program is designed for someone who has had longer standing, more recurrent, more and perhaps potentially undiagnosed back pain. So if someone who's been experiencing back pain for some time may have had some treatment, but really don't really understand what's going on with their back pain, don't really understand what the cause of it is, don't really understand how they best manage it. And so again, it's really about someone needing sort of help to deal with a recurrent problem, or if they feel that prior treatment's not been effective. Again, it's treatment initially by a physiotherapist, providing expert assessment, a diagnosis, education around what you as an individual need to do. But the other thing that this program consists of is also work with our strength and conditioning team. Okay, so it's a specific, bespoke, tailored exercise program, because we know that exercise is absolutely key to sorting out recurrent and long-standing back pain. And it also provides access to our gym space to allow you to get on with that. So, so it allows people to work at home on their exercise program, but it also allows you to work with one of our expert teams. So it provides you that confidence and reassurance that you're doing the right thing with regards to, progressing and improving your back pain. And then the last package is for someone who has a complex problem. So this is someone who has potentially seen numerous clinicians, tried various treatments, but never really got to the bottom of what's going on or experienced a lasting improvement. And this is really the multidisciplinary team approach to managing back pain. So it involves our consultants in sport and exercise medicine, our physiotherapists, and again, our strength and conditioning or our Pilates team. And again, we design a bespoke package that's particular to you to help you, a structured approach that is a periodized program, exercise that steps up in various different levels so that it's not an all or nothing approach. And it really helps to guide that individual from that point of recurrent problems to and really improving their function, understanding their back pain more specifically, understanding how to manage it as an individual themselves, and really giving them confidence that they know what's going on and they know what they need to do should they get a recurrence of back pain. And as we talked about, it's not uncommon for people to experience recurrent pain, but what people need to, what we want to get people to is the confidence to then not worry about it and to actually know what they need to do as an individual to manage that recurrence and things. So these are summaries of the 4 packages that we offer. If you're interested, there's further details on our website. In addition to that, there is a number of different blogs around a lot of the information that we've talked about today. So in terms of talking about the sort of myths and misconceptions, in talking about the healthcare information that's out there, and in talking about the latest thinking around back pain. So I know that we've provided you with an awful lot of information this evening, but our website does have a lot more information for you to go and review and really revise what it is that we've talked about to ensure that you are confident with what we've told you. So we've still got a few moments for some other questions. So Stephen, is there anything else that you, any other questions in the Q&A function?
Yeah, there's a few. I've tried to answer a couple while you were explaining the packages there, just typed some answers. I'll pose one of them. There's one in the chat function, and I'll come back to the Q&A. Nick Vanzen mentioned that he also enjoys running and that he has been part of a running club for many years. He's currently a 64-year-old patient who has been told that he has some degree of spinal stenosis, and although it is getting better, he wants to continue running for as long as he can. And his question is there any reason why you should cease running with spinal stenosis?
No.
Yeah, that's what I was going to say. I was waiting for you to say it first. My answer to that would be you can run all the way up till the day is done. Basically, you can continue to run, and the evidence about running actually would support that. Running is a very good activity for hips, knees, and lower backs. And actually, if you're running up to 3 times per week at regular intervals, you're actually 4 times less likely to develop hip and knee arthritic changes. So actually running, it's probably keeping your back in check. So I'd say keep going.
Exactly. And I think that's one of the other things, you know, a lot of, I work at a Kensington clinic, and we have a lot of an older patient demographic there than some of our city clinics. But I think one of the reasons why patients like coming to see us at Pure is that we don't say to them, well, at your age, you just have to put up with this, or you need to slow down. And in fact, if anything, it's the exact opposite. You know, as we get older, we need to do more, not less, to keep ourselves, you know, mobile, to keep ourselves healthy, to keep our joints strong. We know that muscles are fantastic shock absorbers, and they protect our joints and things. So actually, as we get older, we should be really looking at investing in ourselves in terms of things such as strength conditioning programs that help us keep the various different muscles of our body in really good condition, so that we can then continue to do all the things that we actually love.
Another good question here that was asked earlier is actually the opposite of sometimes what we talk about. Describes he describes themselves as fairly active, but they also struggle with lumbar flexion due to pain. And what advice would we give this type of patient? And to give a kind of example of that, I suppose from my end, this is a common complaint in terms of we often get tarred with the brush of patients being inactive and not doing enough activity to kind of get rid of their lower back pain. But actually there is patients who are high sports athletes can also get a large degree of back pain. And there's some recent studies that support this. And actually they can be doing too much. Like any structure in our body, you can do too much to things and you can also do too little. So for that particular patient, I would want to look at what kind of activities they're doing, and I'd like to explore how they feel about bending their spine and what's the big challenges with bending of their spine. And I would want to look at how that patient moves, and then I'd probably prescribe some bending style activities or exercises that will allow them to get back to that at a low level. I'd also want to explore the types of exercise they do, whether it's a HIIT style training or strength training, etc. And those types of things would give a different kind of outputs for me.
There's a couple. One of the questions that's come in the chat is, why does low back pain treatment always have to be generic? Every consultant I've seen tells me I have an incredibly strong and stable core, yet each time I'm referred to a physiotherapist, they just give me more core work to do until the pressures from my insurers leads me to discharge me without improving my pain. I think hopefully we've answered that to some extent, which is, you know, it's not all about the core. And in fact, one of the things that in terms of looking at a bespoke and individualized approach to care is that when you are assessed, you should be looking at your whole movement patterns. So seeing, you know, do you lack flexibility? You know, are you actually too rigid? Do you actually need to learn to relax your core? And so I think that, you know, again, there shouldn't be a generic approach, you know, and that is, you know, the evidence would suggest that treatment does need to be individualized, and that it needs to be looking at how people move and addressing any issues there, as well as addressing all of the other things that we've talked about in terms of sleep, in terms of stress, in terms of, you know, general fitness and things as well. So, you know, I'm sorry that that's been your experience of physiotherapy, that it's been generic and it's been core focused. It shouldn't be.
It's a really unfortunate, because that's, as you said, Claire, already, it's a common thing that I would see as well with patients. As I said, I like seeing patients who've sometimes been bounced around an awful lot, and it's usually because that same type of pattern, they haven't been bespokely looked at or given a package of treatment that suits their needs. I would say very boldly, I'd say, come and see me, we'll sort it out. I promise you won't get any core exercises from me on that one.
So we'll just take a couple more questions from the chat. One was asking about, is there a good mattress for back pain? Again, there is no evidence around there being one mattress that works more effectively than any others. And the advice that I would give patients in terms of going and buying a mattress is that you need to spend some time. You need to spend time doing it. So you need to go and lie on a lot of beds. You know, if you've got a partner, with your partner, and you need to spend time, you know, seeing what's comfortable. And, you know, comfort and a lack of pain is really good guidance for all sorts of aspects of medical care. So it's the same thing with a lot of footwear. If you're comfortable and you're not in pain, then that's a good thing. So you know, some people prefer a very firm mattress. Some people actually like something that's a bit softer. It really is a case of going and trying it out. But you can't just lie on a mattress for sort of 5 minutes and think, oh, okay, I've worked out that feels fine. You've got to lie there for a good sort of 15 minutes or so to really see what feels comfortable for you.
Absolutely. I usually tell patients what's most comfortable is your best mattress. Whatever they think is the most comfortable.
I mean, we've answered the questions around, I think, core stability and things, and the fact that it's not necessarily about poor posture and weak core muscles. I think that it needs to be, there's no, you know, one approach to that. It really does need to be a case of looking at your whole movement patterns and looking at you as an entire individual and things as well. So yeah. So, and I think just finally, someone's asked again, someone who is fairly active but struggles with lumbar flexion due to pain, how can you advise this patient? And can you take us through an example, please? Again, it's not possible to give a sort of one size answer to that, because the reason why someone may struggle with lumbar flexion is very different, very individual and things as well. It may be that they have very tight muscles. They may be tight hamstrings, but that may be putting more stress and strain on their low back. It may be that they've actually got really tight and rigid low back muscles. That means that when they bend forward, that things, you know, it's painful as well. And again, the other thing is that we need to consider is that restricted lumbar flexion, you know, can be an indication of some of these inflammatory conditions that we talked about. It's rare. As Stephen said, it's 3 to 7% of the population. But what we commonly see is that a lot of people have seen a lot of other people, and those inflammatory components have sometimes been missed. So, you know, it's not a case of forcing anything either. And the other thing is that sometimes, you know, while we would say that most people should be able to touch their toes, it's not necessarily essential for normal pain-free, you know, daily living and things. So, you know, it depends on how it affects you in terms of, you know, long-standing back pain as well. Stephen, is there any other sort of questions and things in the chat that you would like to answer? We realise that we're 5 minutes over, but obviously people are free to drop off if they feel that they've heard enough and things. If you want any further information, it's all on our website and things specific to our back pain program, but also information around our blog pages and things as well. So.
Yeah, I don't think I have anything else to add. I suppose the last question I've seen and the last question I'll answer would be from Jeremy Newton, who talks about having an L3-4 nerve impingement, which caused him to have some sciatic and muscular atrophy in his left leg. Thankfully, the back pain has gone after 3 months, but he does have some discomfort behind his knee and in his thigh. Good to hear he's doing strengthening exercises, which include squats and lunges, and his pain is reducing day by day, and he's no longer on painkillers. He's currently looking for any additional advice that I would suggest to recover the muscle in particular, and for pain relief, or just to reassure him that he's on the mend. And really the main point I would take from that is to reassure you that you are doing the right things, and nerve irritations or nerve injuries take quite a significant amount of time to recover from, particularly something of that level. So you're doing the right things. I would say keep doing it. The consistency in your approach is what's going to get you there, and making sure that those exercises are variable and progressive. And I promise you, over a period of time, you will certainly see some more improvements.
Just answered a couple of questions in the chat. Just finally, one of the questions was around slouching and saying, you know, is slouching bad for you? I think as we've sort of said, you know, there is no such thing as bad posture. So no, slouching isn't bad for you as long as you don't spend too long doing it. So you change that position. Slouching is for long periods of time is as bad as standing rigidly upright is. We're not made to hold any one position for too long. So, you know, the adage that physiotherapists use at the moment is, you know, your best posture is your next posture. So changing position and movement is really what's key to pain-free, you know, lives really. So. Well, I'd just like to thank you all for your engagement and attendance this evening. It's been really great to get so many questions in the chat and things. And I hope that we have answered, you know, all your questions, and that we've given you, you know, some valuable information. We've helped you perhaps gain a better understanding of why you may be experiencing back pain and things. You know, if people do have questions that they'd like to ask, please email our info account at puresportsmed.com. So it's just info@puresportsmed.com, and our reception and admin team will pass the question on to one of our specialist spinal musculoskeletal physiotherapists to answer and things, and to give you some guidance and things on the questions that you've got. Because, you know, there are, you know, lots of very specific sort of things that people are concerned about, and we do want to try and help spread the word about with accurate information about back pain and things, and to provide, you know, reassurance and advice about how people should be managing their problem and things as well. And also, if you've got any sort of comments or feedback on the information tonight, on our packages and on the presentation, we'd really value that. So again, please send that through to the info account at puresportsmed.com. And we look forward to seeing you on other future webinars going forward. Thanks very much, everybody. Bye-bye.
Thanks all. Good night.